leaders here today will talk about the CQI model and how it's really working. Blue Cross is proud to provide the foundation and structure for the 12 active CQIs, and we're excited to have several additional initiatives under consideration for next year. More than 70 hospitals participating in at least one CQI. These efforts are positively impacting Michigan healthcare and improving safety for all Michigan patients. CQIs prevent complications, reduce hospital lengths of stay, and improve outcomes. And we've always known these quality improvements were saving valuable healthcare dollars, and you know, today we can tell you how much. Four of the longest running CQIs have gone through a thorough actuarial analysis, and we can confirm that they have saved $232.8 million in claims payments over 3 years. And $70 million of that is to Blues members. And you know, that I think is an important aspect of this program. We've got $232 million, almost $233 total dollars being saved. 70 million of that at the Blues, but what's interesting is 150 more million of that has nothing to do with the Blues. We knew that going in, and are proud of the fact that we're doing this and raising all boats. And that's really what this is about. It's about patient safety. It's not about Blue Cross safety. It's not about Medicaid safety. It's about patient safety. And I think when you look at these numbers, it's really exciting, and that's why I was so proud to come here today to talk about this. You know, cost savings, improved quality of healthcare outcomes from these initiatives are proof that the Blues model of collaboration works. The Blues, physicians, and hospitals across Michigan are transforming healthcare for the future. And I'm really proud that we're doing it together. And I'm, you know, no doubt, as sitting with our team as we're working through this, there's no way that we could have done this without partnering. You know, you can't. These kind of numbers don't happen without full collaboration. And I'm just so very proud of what we've done at Blue Cross Blue Shield. You know, we talk. Things are so complicated with healthcare reform. We talk about all kinds of issues. It's fun once in a while to talk about, you know, things that are really making a difference for people. And I'm really excited to make this announcement today. And now to close my portion of the program, I'd like to introduce Dr. Jack Billy, who's the Associate Dean for Clinical Affairs and Professor of Internal Medicine and Associate Vice President for Medical Affairs at the University of Michigan Medical School. Dr. Billy has played a crucial role in the success of CQIs because he's been a valuable partner and a visionary leader. Dr. Billy, can you come up? Thank you.
Really a pleasure to be here. Of course, I'm not an expert because an expert is someone from out of town with slides, and today I have no slides. But I do want to tell you that it has been an absolutely outstanding partnership between the University of Michigan Health System, our faculty, physicians, nurses, and staff, and folks at Blue Cross Blue Shield of Michigan in value partnerships and in the collaborative quality initiatives. It has just been one of the most exciting developments in my 35 years in healthcare in the state of Michigan. And in a way, it's because Blue Cross and the University of Michigan have so much in common. We both are organizations that span the state of Michigan. We receive patients from every county, and in fact, Blue Cross insures people from every county. We also play a role as the facility of last resort for really sick, complex people, and Blue Cross plays that role when those people need insurance. But most importantly, we have a commitment in our institution, as does Blue Cross, to improve the health of the people of the state of Michigan and to improve the health care that's delivered, the safety and the value. And I think, as Dan pointed out, one of the best aspects of this collaboration is that folks often say, well, you can improve quality, but it's going to cost you more money. We can increase safety, that'll cost more. But here's a perfect example of how a dedicated group of experts in their field working together with collaborators across the state have been able to improve quality and efficiency at the same time by understanding root causes of problems and running little experiments to get improvements, and then locking in and passing around their colleagues what they've learned from those places. And we'll hear more about some of those outstanding examples. So we've been working for over a decade based on a report from the Institute of Medicine crossing the quality chasm that unfortunately, even though it's over a decade old, is still way too true in terms of all the gaps that we have in healthcare delivery in this country. But you can either curse the darkness or light some candles, and today we're here to celebrate the fact that we've lit so many candles. In fact, the nation is looking to us as a model. By the way, some of you are worried about the Supreme Court case. Of course, there's nothing to fear at all, even if some parts of the Affordable Care Act are struck down. All of the good work that's is the example today will still go on. That's not dependent upon any acts of Congress. That's dependent on the dedicated actions of a small group of people who understand the work and are trying to improve it. But we certainly couldn't do this kind of work without the help of a lot of folks. So if you think about it, why would the University of Michigan get involved in this? One thing I've told you about, we're trying to improve quality and health of people across the state, and Blue Cross helps us to leverage that through supporting the CQIs. But the second, maybe more important reason is we need to improve ourselves. We have the same kinds of gaps in quality, safety, efficiency, appropriateness, and service that are found throughout institutions around the state. And one of the things that impresses me most about the collaborative quality initiatives is there isn't hubris going into it. There isn't this concept that, well, we know the right way to do it. There's a genuine sense of discovery. We don't even necessarily know the problems going into it, but one by one, through careful, patient work at the different places, we discover the problems and then discover what seems to work, as Skip pointed out in his brief introductory video. So from our perspective, we have a lot left to do. We certainly are on a good start, assuming no problem is problem, always assuming there'll be problems, going to the real place where real people do real work to learn more about what things are, understanding root causes, which may differ from one place to another. This concept of sharing the learnings, continuing to put on such great collaborative meetings that stretch the minds of the people working in their own institution. So on to the thanks that I have to give. First of all, great thanks to Blue Cross for their insights, to Dan Lepp as the CEO for supporting this program, and the rest of the executive leadership, especially to Tom Simmer, we'll introduce in a moment, to David Scher, Tom Lydon, and tremendous staff in all of the Value Partnerships program. Also the other senior leadership of Blue Cross, who in their own way supported, either in hospital contracting strategy or in sales, in order to understand this unbelievable gem that Blue Cross has helped us create. And special thanks to the staff and faculty at the University of Michigan and the nurses who do the work of a coordinating center for so many of these, and the staff that support that activity as well. But I think our most important thanks goes to the doctors and nurses and staff at each of these participating institutions, because they're the ones who discover what's going wrong with the way care is delivered, and are so courageous to point that out and to collect the information to try and make those improvements. And my thanks is not just for me, it's actually on behalf of the patients that will never know their names, the ones whose lives have been saved through this, who avoided a complication, and also for the employers and others who end up paying for all that care. So there's a lot of thanks to give and a tremendous amount to celebrate today. Thank you very much. I'd now like to introduce my partner in crime, Tom Simmer, the Chief Medical Officer, Senior Vice President of Blue Cross Blue Shield, one of the leaders who inspires and also supports this activity.
Thank you, Dr. Billy. I also want to thank everybody that Dr. Billy thanked in the same order. It's just amazing. What I'd like to talk a little bit about is, why do these programs succeed? All of us are aware that American health care faces serious challenges, and these challenges often seem to be unsolvable. And I think that the celebration that we have today is that they are not unsolvable, but they take a new approach that we haven't been using. Our goal is to create a really high-performing healthcare system in the state. And we do this through partnership. And we start off confident that partnership will work because look at the missions of our organizations. Blue Cross Blue Shield of Michigan exists to offer the citizens of Michigan access to high-quality, affordable health care. The physicians and other professionals throughout the state, their mission is to promote the health and reduce the disease burden of the people they serve. So how do we take this common mission and translate it into really successful results? We realize that physicians, nurses, and other healthcare professionals don't need to be motivated. Physicians and nurses are very attached to their patients and feel very strongly in each individual case the need for a successful outcome. We clinicians want to help our patients, and the last thing we want to do is walk into a room where the patient has suffered harm from our care, a wound infection, failed kidneys, or even worse, death, and talk to the patients or family and say, I really regret to tell you that you have been harmed by our care. We know that that passion for delivering better quality is already resident within these clinicians. How can we harness it? And the simple answer is support them with people who can bring them the information that they need to improve and defray the costs of bringing them together and working in partnership with their own colleagues to identify those best practices and to turn best practices into everyday practice throughout the state. What it requires is leadership on the clinical side and leadership on the payer side to say, this is something we're going to do, this is something we're going to support. The next thing you know, these wonderful leaders, many at the University of Michigan, bring their colleagues together, create a really good information system that everybody can trust the data. They create a safe harbor where people can work together without suffering harm. And then they go out and achieve these amazing, amazing results. So really, this is a model for the rest of the country. It's hard for me to understand why it took so long for us to decide that this is what we're going to do. But I also do want to also thank Dan Lepp, the CEO of Blue Cross Blue Shield of Michigan, for sticking through what has been not a short journey, but a long journey. And I think that's the other point, is that when you work in these partnerships, you realize you're creating a fundamentally better approach to care, and that takes time, it takes patience, it takes trust. And what we've created, I think, that's really, really making me optimistic for the future is trust. And it's not just trust between Blue Cross and the clinicians in the state of Michigan. It is the trust that I see developing within the medical community itself. We really are creating a medical community where the practitioners know each other, seek to learn from each other, and actually work together in many venues that go beyond the very specific ones that we're talking here today. And it is just such a joy to me to see a medical community that is brought together in this way and achieving the amazing results. I think it's worthwhile for everyone to just reflect on what it means for you, if you're the patient who, as a consequence of receiving this contrast dye in a cardiac catheterization, that your kidneys fail. What does that mean? That means you go on dialysis. That means that 30% of you don't make it out of the hospital alive. These are pretty serious things that you want to avoid. I think the gift of not having someone suffer that complication is such an enormous gift. And that's just one example for one person. And many, many thousands of patients have benefited from the hard work of the people who are going to be speaking with you in just a moment if I give them a chance. So with that, I probably should give them a chance, and I will say, again, thank you. I can't describe how important I think the work that you're doing is and how great the accomplishments are. The reality behind the numbers is really staggering. So with that, I'd like to turn it over to Dr. David Scheer, who actually was present at the creation. And that's not a coincidence because he's the very first person who put together, in collaboration with the colleagues at the University of Michigan, the very first collaborative quality initiative.
Thank you, Tom. So it is exciting to be here. It's exciting to celebrate these accomplishments. When we use the word partnership here, we're not talking just about a partnership between Blue Cross Blue Shield of Michigan and the University of Michigan Health System, or even just between those two entities and the 70-plus hospitals in the state that are involved in these collaborative quality initiatives, but also the hundreds and hundreds of physicians and thousands of nurses and hundreds of thousands of patients whose lives have been affected by these programs, affected as practitioners because they've been empowered to do their best through participating in this approach to collaborative improvement. And the patients and their families who have been empowered to have healthcare experiences which achieve better value for them and, most importantly, more fulfilling lives, safer care, and better outcomes. When you contrast the results that these programs have achieved in terms of saved lives and decreased complications of care and saved dollars as a result, and as has been pointed out, it's not common to achieve all of those together. With pay-for-performance programs and public reporting programs, which are really the common currency of the day, it's really quite striking because the standard programs tend to shine tiny little spotlights on evidence-based opportunities to improve processes of care. But when applied with modest incentives in the real world, there's good evidence that they actually don't achieve very much. In contrast, if you, instead of having external folks measure the work of providers, if you empower them to come together to share data and measure their own work in real time, in real practice, across an entire state, they've proven beyond a shadow of a doubt that they can dramatically transform the systems of care in which they practice and the outcomes which those systems achieve. So I like to think of it as moving away from the concept of evidence-based practice, which everyone talks about, because the evidence base is actually pretty thin and only covers a very few aspects of care, especially the complex care that tends to happen inside of hospitals. And moving toward a concept of practice-based evidence so that real-world practitioners aren't just taking rarefied data from subsets of cases in randomized controlled trials that don't actually reflect patients they see in the real world very much, and instead taking the real experience they have across an entire state, not just a few cases, but the entirety of the practice in almost all of the centers that serve patients in this state, pooling those data collaboratively across competitive boundaries and learning from having done so what works in the real world, and as technology evolves, having the capacity in almost real time to generate new knowledge about what works as technology evolves, and then to systematically implement that in their own practices. So we're talking about harnessing the intrinsic motivation that was referred to earlier, that doctors and nurses want to do their best. They have a tremendous amount of energy to give to that. Harnessing that fully and empowering them to be self-optimizing as a community. It's quite an achievement, and I think something that we should all be very proud of. So with that lengthy set of introductory remarks, I'm going to now introduce Skip Campbell, who is the Chief Medical Officer at the University of Michigan Health System and also the Program Director of the Michigan Surgical Quality Consortium, which, by the way, just had its major 3-day annual meeting very successfully with nearly 300 attendees at the Renaissance Center, ending just today at about noon. It's been having meetings regularly with its collaborators on a quarterly basis. This one was sort of a pinnacle kind of experience and evidences the extraordinary engagement in the MSQC.
Thanks, David. Yeah, that was, I'm still kind of in the digesting what a great conference we had, but to me it made all the difference in the world, because I remember when we started off with our small group of hospitals, nobody knew each other, and now we have these 250 or 300 nurses sitting together with doctors and several administrators as well, talking about what's really the best thing for the patient, and that's a very gratifying experience. So the Michigan Surgical Quality Collaborative, now, oops, you have a map there that I was going to show. That actually happened once in a different setting. So this is a map of the Michigan Surgical Quality Collaborative. There are 52 hospitals at the moment. We're trying to expand even more beyond that. But the point of this, showing you this map, is it's fairly well distributed, even the hospital up in the Upper Peninsula that participates with us in what we do. And this is typically the kinds of information that we provide to the participating hospitals, and it's such a tribute, I think, to Blue Cross Blue Shield that they have not insisted on knowing who is who in terms of what their results are, who's the worst performing hospital and so forth. And that was really one of these trust issues that was so important to our development, that hospitals would be willing to participate under these conditions. And this is what you see here. The bars on the x-axis are different hospitals in our collaborative, and there's a percentage wound infection on the y-axis. And you can see the red boxes indicate that there are some hospitals that had problems. They're struggling in terms of their wound infection rates for clean elective cases. And then on the other side, there's some hospitals that are actually doing very well. Hardly any wound infections in the 3 hospitals at the side of the graph, over 2,000 cases. So what we strive to understand is, why are they doing that? How can they be so good when the rest of us are struggling? So I think the key parts of that is we've found a way to go into those hospitals and get the trust of the people, so they will actually let us come into the hospital and spend a day with them, and then to ask them these very down-to-earth, at the bedside kind of questions about what makes your hospital so good. And then we take that information and then we disseminate it to the rest of the 52 hospitals. And I can't make you do this, but it's just information that we found. We think it's helpful. Why don't you try it? And that seems to have worked very well. One of the things that we developed, to give you a concrete example, is we now have a very extensive database of almost 200,000 general surgery cases. And out of that, we focused on colectomy, which is the removal of the colon. That's a common general surgical procedure, and it is fraught with quite a number of complications. Looking at that database and then going into the best performing hospitals, we came up with what we call a bundle of 6 different process measures that we think are associated with very low infection rates. That came from our own data. This is not something that's a national kind of effort. So implementation of that bundle is the goal for the next few years, but that kind of process has resulted in a reduction of complications of about 20%. And this slide sort of demonstrates how that relates to cost. On the left side, the bar is the costs from expensive complications that we incurred at the beginning of the program. And on the right side, after we've improved and we've avoided many of these kinds of complications, it's less cost. And what is less cost to? Well, it's less cost to the hospitals, participating hospitals, but also less cost to the third-party payers, i.e. Blue Cross Blue Shield. Next slide. So I like this slide because we all understand that culture is really important. Developing the right kind of trusting and cooperative culture is essential, but it doesn't just happen overnight. You have to work on that. And what are some of the structural features that resulted in the culture that we think was ready to improve? They're the financial support from Blue Cross Blue Shield. As I mentioned, the payer is agnostic to the results. We have a pay for participation model where there's equity in the way hospitals are compensated for their activity. The doctors have to believe in the data. If they don't, all is lost. We have regional rather than a national organization. I think that's so important because we get to know the providers. And we have meetings every 3 months where we sit down and talk about these things, and we get to know them over time, and that facilitates the sharing of good ideas. And then it's multidisciplinary. There are very few surgical meetings where you actually see the surgeon sitting next to the nurses, sitting next to anesthesia, sitting next to administration. That's so important in terms of trying to improve results. So the result is a culture that has high quality workers. It's not threatening, it's not competitive, it features engagement. The site visits are welcome by the hospital. And then I highlighted in red here, there's this interest in discovery and innovation, trying to really wipe the slate clean, and can we do better faster? And so here's just one slide that kind of shows how we've tried to broaden the interest that we have in our collaborative. It's not just the middle column, which is the prevention of expensive complications. Of course, that's very important. But we started to wonder, couldn't we also prepare the patients for elective surgery much more organized fashion than heretofore has been the case? And so we developed a checklist of all the different things that actually should happen. And they have to do with smoking cessation and progressive ambulation and control of diabetes and a number of different things on this list, but they're all things that are just a matter of organization. We can do it if we just think about it. And so we call this the preoperative boot camp that we're initiating this year. And then on the other side of the slide is this business about rescue after complications. So what we found is that while hospitals always have complications, they vary greatly in their ability to rescue a patient once a complication occurs. And why would that be? Well, it might be some structural features like whether or not they have a rapid response team, or do they have nurse staffing that's sufficient on the weekends and at nights, and so forth and so on. So we can go into hospitals and say, you know, in many ways you're good, but why are you losing so many patients once they have a complication? That's a very important aspect of what we do. Next slide, Jay. Okay, so then I'll stop there by saying I think that we've developed this culture of trust within our group. There's a lot of things we've got on our plate. We're looking forward to going into the future and saving even more money and improving the care of our patients.
Thank you, Skip. So next we'll hear from Dr. Katinder Gurm, who is the Director of Inpatient Services for Cardiovascular Medicine at the University of Michigan. And he he's the Program Director and leader of the BMC Squared project, stands for Blue Cross Blue Shield of Michigan Cardiovascular Collaborative. Say that 5 times. You see why we call it BMC Squared. And it is the first and flagship CQI project, which began in 1997 after a year of planning and conceptualization, which led to a partnership with the Blue Cross Blue Shield of Michigan Foundation, which actually provided the initial funding for that project as a test, a model of whether this approach could work. And in fact, within 4 years, there were dramatic reductions in death rates, in complication rates, better functional status for the patients, and substantial savings as a result of all of that. So that's what proved to us that this could work and helped to spawn the rest of the programs that we're now equally excited about. So continue, please.
Thank you. So it is indeed a privilege to be here and talking about BMC to BCI. Well, first of all, I'd like to thank all the people who were involved in setting up this collaborative. Share the Blue Cross leadership, Maura Vespucci, who's not here, who's the Chief of Cardiology at Miami, and the other interventional cardiologists in the state of Michigan who got together and developed this registry. Now, this may seem like a great idea now, but you're thinking of interventional cardiologists. These are all alpha docs. We're trying to get alpha dogs that compete against each other to sit down together and come up with a concept that we're going to work together and help improve outcome of all our patients. That was a novel concept then. 15 years later, it's a highly successful model, something that we are really proud of, and I can say that every patient in the state of Michigan can go with confidence to the hospital when having a heart attack and get good care, knowing that there's an ongoing collaboration that's working actively to improve their outcomes across every hospital in the state of Michigan. So these were the starting preambles of all the things that we want to look at. We want to improve the quality of care of PCI, overcome the barriers of traditional competition, and then improve data collection, improve data modeling so that people know exactly what they're doing. This is where we are now. It started out with 5 hospitals. There are 33 hospitals in the state of Michigan that do PCI and have surgical backup. These 33 hospitals all participate in the registry. So this is how this process works. Unlike any other registry, well, we share some of the things with the registry. The cardiologist performs an intervention, the data is sent to the coordinating center. The coordinating center then generates a report, then sends the report back to the hospital. With the key difference, we identify the opportunities for improvement. We identify where the outliers are. Then there's focused efforts that may be local, or they may be across the collaborative, or they may be with a few hospitals involved that want to focus on certain procedural safety efforts. Those efforts, the lessons that are learned are then shared with everyone. The idea is that what works for us, now we'll share it with everyone else so they can figure out what works for them, modify it as they deem fit, and then apply it to their institution, and the cycle goes on and on. So this is the first 5 years. This is a slide that I often share with my interventional colleagues, and I'll tell them, well, just look at the bar. If there's more than one, that's bad. If there's less than one, that's good. Here's a more sophisticated audience. Ladies and gentlemen, know what we're talking about. These are observed to predicted ratios. So the green bars are the intervention group that started this program in the beginning. The yellow bars are that same group in 2002, so 5 years later. The control group is the hospitals that joined the collaborative in 2002. So you can see everything got better. With time, technology improves, everything gets better. However, everything got better far more in the intervention group than in the control group. So this was the first example, the first validation that this model actually works. It helps improve outcomes, and it improves outcomes far more than just knowing the data or improvements that are would be expected with the changes in technology. So we looked at what happened subsequently. So these hospitals joined the collaborative. The same hospitals have been working already, and we see further declines. Now someone might look at it and say, 0.5% decline, who cares? 1% decline in a complication, what's the big deal? Well, put it in absolute numbers. 30,000 patients a year get PCI in the state of Michigan. 0.5% reduction in death rate is about 75 less deaths. 1% reduction in transfusion, 300 patients less are getting transfusion across the state. These are real people, someone's dad, someone's granddad, someone's grandmother, alive versus dead. These are real important things. There are other benefits, we'll talk about them, but I think first and foremost, these are real patients who are benefiting from this quality improvement. Now, when we looked at this data, we were really happy. There was a round of self-congratulation. We patted each other on our back. We patted ourselves on our back and said, look, we really wanted to work. But then what next? We've already driven the complications down. Can we do better? And so in 2009, when we looked at this data, we said, we're doing good, but can we do better? So we set goals. Up to that point, we had worked without setting goals. We provide feedback and give sites an idea, are they doing better than average, are they doing worse than average? And we came up with these goals based on the worst 25% of the hospital. So that was the cutoff, and we wanted to bring the worst 25% of the hospitals back to do better and come and figure out why these hospitals were doing better or doing worse and try to improve the outcome. So every hospital got a slide or a letter that looked like this related to every complication. So this told the hospital that you were number 25. There's the goal, we wanted to be below this goal. And here's other hospitals are blinded, but that gives you an idea that there's a huge variation in outcome. Some of it may be related to patient care, but some of it's actually related to the processes of care. So we approached this in two fashions. We wanted to improve the outcomes in hospitals that were not doing so well, We wanted to go visit the hospitals that were doing better and try to figure out what was it that they were doing well. So we organized site visits that went specifically and did a thorough walk the walk. We looked at what were they doing to the patient before they entered the cath lab, what was different in the cath lab, what was different after they left the cath lab. So we then took those messages and tried to collate the best practices and shared them across the entire consortium. Now here's some interesting data. Before we even shared these best practices, knowing that we had a goal, we saw a decline. So the blue line is the outcomes in 2008. The red bars are the outcomes in 2009. So you can see hospitals that were doing poorly did better, but some hospitals that were doing really well also did better. And there were some hospitals things didn't really change that much. However, that was the first year before the data had been shared and before we had gone and specifically focused on the goals. And here is what has happened subsequently. So we've seen a steady decline. And in the last few years, our technology and equipment, nothing has changed. And yet we are seeing a steady decline in 3 complications: contrast-induced nephropathy, transfusion, vascular complications. Death rates are fortunately very low. Emergency bypass has declined to very low, and we want to focus on things that are very, very rare to try and see if we can reduce them further. But this is sort of a living example of how, with the focused efforts, setting goals and sharing the data, we can really, really make a difference in improving outcomes. And complications that are rare, they can be reduced even further. Now, why do we care? Like I said, this is real people having complications. That's a good enough reason. But these are complications that are very expensive. If a patient comes to my cath lab and I mess up and the patient goes for a bypass, the cost of that is almost $100,000. So as any bypass that's avoided, if it's done in a controlled setting versus done in an emergency, the cost savings are obvious. A transfusion, depending on the analysis, is somewhere between $2,000 to $5,000. Contrast-induced nephropathy, $13,000. Really expensive complications. And even a slight reduction from 3% to 2.5%, that 0.5% adds up to lots of dollars. Where are we going further? You know, we focus on the complications. Now the collaborative is looking at, do we need to do all those 30,000 procedures? It's a very small percent. That may be procedures that can be avoided. These patients will be better treated with either surgery or could be better treated with medication. So the next focus is on appropriateness. So I'd like to conclude that this is a living example of what I think the blues leadership and the interventional community 15 years ago wanted to create. That was their vision, and I think we have the living results, that this is achievable. This is something that other institutions, other states, other insurance carriers, there's a need to take this model and apply it elsewhere. This is something that needs to be an ongoing basis. We have to keep doing this on and on. Quality can be improved and improved further, and it saves lives, it saves money. Thank you so much.
Thank you, Sander. So Dr. Richard Prager, who is the Director of the Cardiovascular Center at the University of Michigan and also the Program Director of the Michigan Society of Thoracic and Cardiovascular Surgeons Quality Collaborative, was supposed to be here today, but unexpectedly was unable to. So that's the end of our the examples that we're sharing with you, keeping in mind that these are 2 examples out of 12 equally, or well, actually a total of 12 hospital-based CQI programs, the other 10 being equally robust. There are, in addition, 6 what we call professional CQI projects, meaning taking the CQI model but applying it in an ambulatory practice setting where physicians, nurses, and other allied health professionals work together to transform the processes of care in the outpatient setting and the office setting based on learning from their collective registry-driven efforts. We have used the word "we" a lot today. You've heard several of the speakers use that, and historically, we have acted as relatively isolated stakeholders, acting in self-interest, thinking that the best result will be achieved. So whether it's as a payer or a provider or an institutional representative, that's historically the word "we" means us narrowly defined. I think what you've probably observed is that the use of the word "we" today and in general in the stakeholder community in Michigan amongst the providers and their blue partners is that the lines are blurred between who who that word we refers to. It's us. It's us collectively. It's us collaboratively. It's us in a community of trust. And that has achieved an extraordinary amount because it's not just a few stakeholders coming together to break down barriers and work in concert, but it's an entire community of caregivers across the entire state sharing a common concern for the community writ large as the entire state of Michigan. So whether you're in Marquette or Monroe or Muskegon or Mount Clemens or anywhere in between, or maybe around the edges of that too, you have an opportunity as a patient, as a doctor, as a healthcare executive to be a part of this extraordinary adventure. Something we're very proud of, something we intend to continue to grow, and we hope to share further exciting news about the results in the future. So thank you very much for your attention today. So I've been asked to let you know that there will be refreshments at the top of the auditorium outside, I think towards the left, and you're welcome to join us collectively as a community to enjoy that. Thank you very much.